Sarel Gaur, another day, another dollar. I'm out here in Glendora, working in one of the smaller hospitals. Now, as an IRDR, working here means reading quite a few diagnostic cases and doing just a few interventional cases in between. This is an interesting issue for IRs that are coming into practice now that want to focus solely on IR. This creates an issue, the coverage of small hospitals. IR is a victim of our own success. Because our techniques are so safe, because of our understanding of imaging guidance, people want to use interventional radiologists to help them work. People being surgeons, people being urologists, anyone that's trying to take care of a patient safely using the latest techniques, they're going to want an interventional radiologist available, ideally 24/7. The problem with a small hospital is, how do you attract an IR to that hospital? Because there's basically challenges. The main challenge is, you have a hospital that's less than 200 beds, say 150 beds or less, you're not going to have a high IR case volume. Maybe 1 to 2 cases a day, maybe 3 cases a day. Infrequently there'll be some larger cases. But day-to-day basis, there's not going to be a lot of interventional cases, and that's going to be hard to attract an interventionalist. Now, in the previous model where maybe an IR was okay doing 60, 70 diagnostic cases and then a couple of interventional cases that may have worked, but going forward, I don't think that's going to work. The other issue with the small hospitals is you have to have the right environment for an IR to thrive, and that means having a very decent interventional suite. You need a decent fluoroscopy suite, which is large enough, it's well stocked, it needs to be staffed with decent specially trained angiography technologists and special procedures nurses, nurses that have ICU training. That type of training, those type of people, staff availability may not be possible in a smaller hospital. And if that type of room is not available, it'll be very hard for an IR to perform those cases to the right degree. I mean, you'd be surprised what IRs are sometimes asked to do, what type of conditions they're asked to work in. Maybe an old fluoro suite that's used for barium studies, or maybe going to the OR to use a C-arm. Now, these systems are okay, but if you really want to perform IR at the highest level, you need to have the right equipment. So that's another shortcoming. Basically, these things hold interventionalists back at small hospitals. These things need to change in order for the field to grow and evolve. One thing I foresee that I worry about is that if we don't find a way to handle these issues and provide care for the doctors that are taking care of patients at these smaller hospitals, they may figure out how to take care of these problems on their own. I mean, for example, a general surgeon may figure out how to do image-guided abscess drains, or a urologist might figure out how to place their own nephrostomies. The thing that I hang my hat on is that I know from my personal experience that these procedures, even though they look simple enough to the observer, I know how challenging they could be as an interventionalist, how much training and skill you need in order to safely create these procedures on an everyday basis. But still, there's always that threat that, unfortunately, if we can't provide the service where it's needed, then we can be replaced. Basically, what this means is we need to broker a deal. We need to create a deal. Someone needs to come closer to us. We need to come closer to them. Some sort of a deal has to be hashed out, but it takes flexibility. Inflexible people can't broker deals because both sides need to bend a little bit. IRs need to also have decent expectation, or decent standards. They have to say, I'm not going to practice in a suboptimal IR suite. I'm not going to be able to spend my whole day at the institution if there's only a couple cases. And they sort of need to set their own standards and kind of go from there. It's challenging. It's a lot of challenge. It might be too much challenge for a young interventionalist to take on. It might be easier for a young interventionalist to just go with the flow and do a 50-50 diagnostic and interventional role. I'm really curious to see how these IR-only groups are going to evolve and change and grow over the next few years. I think the IR contracts are starting to separate out away from the diagnostic contracts. I think IR groups are starting to form. I hope this is a step in the right direction. I hope that the reimbursement is there so that the interventional only groups can support themselves financially to what they think that an IR physician should be making. A lot of unknowns, a lot of unknowns. But yeah, working in a small hospital, there are challenges, and just want to discuss them so that people are aware of what's going on. Sarel Gaur.